talk about SLO2, the response to labor. So we want to talk about how mom is responding to labor, how her body's responding to it. But we got to talk about labor first. So how does labor affect mom's body? She has to have contractions. The contractions are coordinated, so they're happening on a regular basis. They're involuntary. Mom has no control over them. There are hormones that are released that they think starts labor. And they're intermittent, so they come and go. They're not constant. There is a cycle to them, so we're going to talk about the cycle. So the cycle of a contraction is it starts to increase in strength. That's called the increment. It peaks at the top of the contraction when it's the strongest, and then it comes back down. So it decreases, or it's called the decrement, as it decreases in strength and comes back down to where mom is not having a contraction. So the contraction is the uterus, that big muscle squeezing during a contraction and then releasing in between. That in between time is called resting tone. So the resting tone would be how soft your mom's belly is in between contractions. It should be soft, it should not be firm. When a patient has a contraction, we measure the strength of the contraction by touching their belly. So you put your hand on their belly. When they get a contraction, you're feeling it start to increase in strength. You want to feel at the peak how strong it is, and then you feel like it goes away after, and it goes back to that resting tone. The way we tell that is to compare it to our facial parts. So is it mild, like the end of our nose? Is it moderate, like our chin? Or is it a strong contraction because we can't indent it? It's like our forehead. The things that we measure and document during a contraction for labor are the frequency. So frequency is how often is this patient having contractions, how many minutes apart are they, or how many minutes, half minutes are they apart. So when we document them, it'd be something like 2 to 3 minutes, or 2.5 to 4 minutes is the way it would be documented. When we talk about duration, we're talking about how long did this actual contraction last from the time it started to the time it ended, and we look at it in seconds. And so we would document that as a contraction that may be 80 seconds long. This one might be 60 seconds long, so it gets documented as a range, something like 60 to 80 seconds. The final thing we document was that strength, and we just talked about that, so I'm not going to go into that anymore. I do want to talk about what happens in the uterus when it contracts. So when the uterus contracts, the upper 2/3 of it is the part that's strong and pushes down the baby into the pelvis to have it deliver. The lower 1/3 is more stretchy, and so when that contraction is pushing down, the lower third is stretching up, and that's what thins the cervix. So the baby is inside of there, the contraction is happening in that upper 2/3, the stretching and the dilation and the thinning of the cervix is happening because of the lower 1/3. So when we document a cervical examination, the parts that we document are dilation, so that's done in centimeters, effacement, which is the thinning of the cervix, so this part of the cervix has to thin from the length of 2 inches before you go into labor, all the way down to the piece of paper. So it's paper thin, that's 100% effaced. There's nothing left to that cervix. In the process of thinning out, it also stretches and dilates. The other factor that we look at when we're doing a cervical examination is station. Station refers to how the baby is coming down into the pelvis, and is it even with those ischial spines? We'll talk a little bit more about that later in this lecture. The other thing I need to talk about is how baby is responding to labor. So how does baby's body respond to labor? What are the factors that affect it? So the placenta is how baby is fed. It's how baby gets rid of its waste, and it's how baby gets oxygen. And that happens in the intervillous space in the placenta. So as long as the placenta is doing okay and it's not compromised, babies usually have enough reserve to tolerate intermittent contractions. If the placenta has been compromised, it didn't grow right, the mom has a disease process such as gestational diabetes, pregnancy-induced hypertension, or if the baby has fetal anemia. Those can be problems because those babies don't have enough reserve to tolerate the contractions that they're having. When a patient has a contraction, that baby is not getting enough blood flow through the placenta to take care of their needs during that contraction. But in between, as long as they have enough time in between the contractions, they should have enough time to replace all their needs during that rest period between the contractions. The heart rate is normally between 110 and 160. It responds quickly to labor, so sometimes when a patient has a contraction, what we see is an acceleration, a speeding up of the heart rate. Sometimes we see decelerations, so if the placenta is causing issues, we can see decelerations in the heart rate also. Preemie babies tend to run on the higher end of normal, so a lot of times we'll see 150s, 160s for preemie babies. They're just not as mature. Their neurological system is not able to regulate their heart rate as well, and so because of that, they keep a pretty high heart rate. If we see a term baby, so somebody that's close to 40 weeks, and it has been high for a long time, if that heart rate has been over 160 for any length of time, we need to investigate the cause. So tachycardia, that heart rate being over 160 is not normal for a baby during labor. So we need to investigate what might be going on. And it might be as simple as mom has fever and that increases the heart rate, and we need to take care of that in mom to get baby's heart rate back down. Babies just can't tolerate long periods of tachycardia without causing a lot of problems with oxygenation and perfusion. The respiratory system during labor, you've got to remember that the lungs were filled with fluid while baby's in utero. So the amniotic fluid is all through their lungs. They practice breathing while they're in utero, but they don't actually breathe air. So the way they get their air, their oxygen, is through the placenta, through mom's blood. So now when they get ready to be delivered, they've got to switch over when they are delivered to breathing air, and they've got to clear all that fluid. So during labor, what they think happens is the lungs start absorbing the fluid, and the process of labor causes that. And also, the production of fluid is stopped during labor. So that production of what normal amniotic fluids being produced stops during labor, and you don't have any more. So it helps decrease the fluid that would be in their lungs. As the baby delivers, if they deliver vaginally, they get a squeeze through mom's pelvis. When they're born, it releases their chest afterwards, and it helps push out any extra fluid that might be in their lungs. So it's not uncommon for a baby in that first half an hour to cry and to get rid of mucus and fluid that way, and they may have an elevated heart rate and respiratory rate in those first 30 minutes after delivery.